Board, Thursday, March 19th, 2006. It's good to see you. We do have a quorum, but I expect Ms. Whitehead to join us when she's able to. She might be stuck in traffic. How's everyone doing today? Good? All right. Let's jump in and be respectful of everyone's time. Our first agenda item, public comment on agenda items. Pursuant to Tennessee Code annotated 84412, we reserve time at the beginning of each board meeting for members of the public to comment on items on the agenda. We do have someone that has signed up. Her name is Ms. Zachnite Vargas. And Ms. Vargas, I would love for you to come to the podium, please. Yes, and you have 2 minutes. Yes.
Billion, a registered nurse, the president of the Tennessee Hispanic Nurse Association, and a former employee here at the Nashville Health Department. I was once a child in the Woodbine Clinic receiving vaccines that allowed me to begin my educational journey in this country. I am currently a graduate student at Harvard pursuing my MPH. I have returned home for spring break and could not pass this moment to share my deep concerns regarding Tennessee House Bill 1710 and its impact on our public health departments. This bill seeks to criminalize public servants, deter vulnerable residents from seeking care, increase the spread of preventable disease, and shift health departments towards immigration enforcement, undermining our core mission to protect and improve the health of all people in Davidson County. Public health depends on trust. Mandatory reporting tied to immigration enforcement erodes that trust. In my nursing experience, fear leads people to delayed care, resulting in untreated illness, lower vaccination rates, and increased reliance on the costly emergency care services. These outcomes affect entire communities. This bill also criminalizes public employees. Healthcare professionals are bound to confidentiality. In this bill, failure to report patient information can result in a Class A misdemeanor, jail time, fine, or both. This will create moral distress among staff, accelerate burnout, and risk workforce loss. I respectfully urge the board to issue a public resolution outlining the health and fiscal impacts of this bill and to provide testimony as it moves forward. It will be heard by the House State and Local Government Committee on Tuesday, March 24th, an opportunity for your leadership. As public health leaders, your voice is critical in ensuring policies do not unintentionally undermine the systems meant to protect our communities. Accountability in public spending is essential, but policies that destabilize local health systems are not sound public health practices. Without the care my family and I received in 1999, I would not be here today. Thank you.
Thank you, Ms. Vargas, for making your voice heard. I thought I heard someone speak up. That was out in the hall. There are no other comments for public comment or community voice. That takes us to the next agenda item, board members' declarations of conflicts or recusals on any agenda items. Are there any declarations to be made by any of us around the table? All right, hearing none, thank you. That takes us to the next agenda item, deliberation of the February 12th, 2026 meeting minutes. When ready, I will entertain a motion. Motion made by Dr. Stovall.
Second.
Seconded by Ms. Powell. Any discussion? Hearing none. All in favor of approval of the meeting minutes? None opposed. Motion carries. Thank you. That takes us to deliberation of grant applications. And then after that, deliberation of grants and contracts. Mr. Diamond.
Yes, Chair Franklin, members of the board, we do not have any applications this month, so I'd like to move to grants and contracts. And I would ask the board if we could take these items as separate items, including separate votes on them at the request of Metro Legal. So item number 1 is a grant from the Friends of MAC totaling $20,250. And just as a reminder to the board or any new members that any grants that have tailored targeted funding or areas that are targeted to, we have to treat as grants so that we can track that. So It's broken down 12,500 to the Emergency Medical Fund, 4,000 to the safety net, and 3,750 to the foster program. So we would like a request to approve that.
Okay, is there a motion on the floor?
I move to approve.
A motion made by Dr. Griffin, seconded by Dr. McDonald. Any discussion? All right, hearing none, all in favor of approval? None opposed, motion carries. Thank you.
Thank you, Chair Franklin. And the second item is an MOU with the Nashville Fire Department, and just defines the terms for data sharing, analysis, and reporting of first responder data. And we would ask the board to make a motion to ratify this contract, not to approve. The MOU, my apologies.
All right.
Ratify the MOU.
All right. Would you provide a little bit more context?
Sure.
Just a couple of sentences.
Absolutely. Upon consultation with Metro Legal, the MOU has already been signed by the director and the board chair. So this would just ratify those signatures as opposed to approving the board chair and the director signing after the approval. This is kind of doing
Got it.
things in reverse order.
Okay. Is there a motion on the floor?
I move to ratify the MOU.
Motion made by Dr. Stovall.
I have a question.
We'll get, yeah.
Okay. I second.
Seconded by Dr. Griffin. Discussion.
Discussion. What data are we talking about? So can you just be a little bit more specific about what?
Sure. I believe, and you can correct me if I'm
yeah.
wrong, Doctor.
I just saw the high level.
Go ahead.
You don't have, did you get, is it in the board packet? It was in the, it was in the one that was emailed to us.
Okay.
But
And
if you could
Yeah,
provide a little bit more background.
I think it's largely to do with the REACH program data that the fire department and the health department collaborate on.
Yeah, so we do, using the example of REACH and PIC, those are programs that we used to, as part of the opioid epidemic response. And so we work very closely with the fire department and in a co-responder forum, but the primary data analysis is conducted by our staff here. We look at trends, we look at how many diversions from EDs, for example, how many patients actually get to go get mental health help rather than sit in EDs. And that's what that is. We already do the data analysis. Part of the data analysis what's informing the expansion request that these entities are making. It's showing the effectiveness of the programs, not just in keeping fire EMS doing what they're supposed to be doing, but ensuring that people are getting the help that they need rather than being arrested, for example. And so that's what this is.
That's helpful. Thank you.
Any other questions? All right, all in favor for approval of ratification of this MOU, the Emergency Response and Planning MOU? All right, none opposed, motion carries. Thank you. Okay, so next we have deliberation of Tennessee House Bill 1710. No, yes, State of Public Health. Thank you. Dr.
Right.
Ariola.
Yes, thank you. And it's going to be largely a conversation about House Bill 1710. I do want to mention that on March 16th, as a consequence of the lawsuit filed by American Academy of Pediatrics, APHA, and other entities, there was a temporary injunction on a few of the things that we have seen, including appointments to the ACIP, including some of the changes to vaccine schedule, including some of the changes to COVID-19 vaccine. And so we are monitoring that to see how that goes. Yeah. Other than that, the key conversation today is around HB 1710. We haven't mentioned HB 1711, but I will go ahead and say after Kebera's presentation that I'd like a comment from Dr. McDonald. You and I have spoken about this to the extent to which you are able to share. I'd like some comment after Kebera's presentation about this.
Any questions on what Dr. Ariola has shared thus far? before we move on to the next agenda item? All right, thank you. Ms. Leach, now we have deliberation of Tennessee House Bill 1710. Ms. Cabrera Leach. And while she's coming up here to answer any high-level questions, Ms. Leach did provide, I know we have in our packet the actual bill, but she also provided the bill summary. And so in the few minutes that I had before the meeting, I had a chance to review it. So I'm just going to give the board just a moment to read this in case you have not seen this summary, and that will help us move through this conversation in an informed way. And if everyone is comfortable, we can move on. Just let me know if you're ready to move on. To review first on your own, and then, yes. And if everyone's comfortable with the summary, then we can answer any high-level questions and have a discussion. Yes, go ahead.
I was like, and you can review it and look back and forth like to it and ask whatever questions that you would like as, you know, as the chair is saying. What I can do right now as we're discussing this is putting it out there so that we can learn more about what this bill is saying, both in a public forum, not only for you all as Board of Health members, but for our viewing audience, our community members that choose to come in here. So I'm gonna just go through a rundown of what this bill entails. Again, I'm not the legal person. I'm just a public health and healthcare community health professional of 20 years. So if I legally misspeak, Mr. Derek Smith.
Well, actually,
please, I'm just describing what is in the bill and what it refers to. What
and let me be clear. This is not a legal conversation. Yeah. This is an informative conversation.
Exactly.
And the health department, the local health department, is well mentioned. It also involves Metro overall. So this is just informational, so we're all on the same page with understanding what's in the bill.
Yes.
Okay.
Exactly. Okay, so one of the places that I wanted to start, and you'll see this at the very top of the bill summary, that this incorporates local government entities into the Eligibility Verification for Entitlements Act. So for anybody that is unaware, this act that is referring to in the opening line of the bill summary is an act that mainly pertains to universities, making sure that students meet the proper immigration and citizenship criteria to receive public benefits at universities. Generally, that's something that was already covered when you fill out a FAFSA. One of the key things to note in that instance is that if you are a DACA recipient, that would bar you from now having eligibility for those FAFSA loans, whereas before maybe you would not have had that hurdle. So this legislation, the HB 1710/SB 1915, is sort of building upon that, but when it comes to the public benefits, specifically of public health benefits. It amends the Tennessee law related to that eligibility verification to include state government entities, local government entities that are now newly defined, especially with the introduction of this and an amendment that was introduced in the Senate a few days ago, and as well as being very explicit when it comes to local health departments. It requires verification of U.S. citizenship or lawful presence for individuals 18 plus applying for public benefits unless prohibited by federal law, and this would become effective July 1st, 2026. So one of the things that we'll get into here is about administrative burdens, and this would add some more administrative work due to that if this goes into effect on July 1st, 2026. So we have here issues of documentation and record-keeping requirements, and these aren't necessarily things that we weren't doing already. Many public health departments, or just anybody that's delivering a public service, was already verifying eligibility for citizenship, and it is a legal right now, with or without this law, to provide services to somebody that is not a legal resident nor a U.S. citizen for public benefits. This is just seeking to further define those things, as well as give the state attorney general the ability to investigate any reportings of wrongdoings, and essentially if we were to deliver care to somebody or deliver a service to someone that did not pass verification of their citizenship. Not only that, it requires the health departments to report the numbers of people that did not pass verification, or did not pass, that's a weird way to refer to people, but that did not meet the eligibility criteria of being a U.S. citizen. Report those numbers, as well as the actual information of those individuals to the proper state authorities that would be in charge of that when it comes to Immigration and Customs Enforcement. So it requires a lot of extra work on the part of the health department and the local entities. There's an attestation form that's already available on the website for the eligibility verification, the previous act as well. It requires us setting up but clarifying and being very clear in our protocols for reporting and coordination of this documentation, whether it be through our clinical staff, our community workers and whatnot, and lots more, a clear, defined protocol to make sure that we are in alignment with the language of this law. Additionally, on top of that, in terms of the workload, the administrative burden, from a public health perspective specifically, we do need to consider the fact that this is something that can have an impact on the people that we serve, whether or not they are U.S. citizens or legal residents. There are those that come from mixed residency households that may need to consider coming for services, whether that might put another family member at risk by obtaining services here, or just an increased burden that people would want to avoid that, and therefore not taking advantage of public benefits that they're fully entitled to, because at the end of the day, public benefits are generally meant to maintain and improve the status of public health. These are the things that maintain the health of populations, rather than when we think about public health spikes or pandemics that come out of nowhere.
Yeah. Ms. Leach, I'm going to ask you to pause for just a moment. I think Dr. Ariola would like to also lean in.
Yeah,
Yes.
I do want to correct. I think the key point that Ms. Leach is making is the additional work that we have to do around here. In public health, we serve everybody. The goal is to create conditions that allows everyone to be as healthy as they possibly can. Some of these reinterpretation of the prior law and this new law there is adding the burden of determining eligibility. Those are not necessarily questions that we ask in public health, that what's your immigration status, not unless it's specifically required. But now we have to. We have to ask those questions, we have to document them, and we have to be accountable to that. I do want to ensure that you don't leave here with the impression that we were doing this necessarily for our programs before, not necessarily. Yeah.
Thank you.
Yeah. Okay. Yeah. I'm sorry. Just to clarify that as a part of receiving any sort of services, just the general course of verification, that is something that's routine, but it's not something that we are seeking to make a part, or making a part of anybody's public health experience. So As I was saying, there are potential impacts on access to care, public health outcomes, trust and community engagement, as well as other considerations around just health equity in general. We, as a public health department, do need to be mindful now as a result of this legislation, which still is moving through the Senate and the House in the Tennessee legislature, about exposure to state audits and investigations potentially, and legal liability for improper reporting or failure to report, as well as criminal liability for staff in certain cases when it comes to this law. There's also the risk of the loss of state funding that comes with this law being passed. If it is passed and goes into effect July 1st, that's something that I think that we should talk about and be able to discuss, or you guys should be aware of when it comes to this legislation. And that can affect a lot of programs, being that this is a health department and we are very heavily funded by grants, whether it's directly through the federal government or passing through the state, as well as consideration for costs around system upgrades, the staff training, and again, increased administrative burden that may come along with this law. So there's a lot to take in. I had a lot to go through here, but I don't want to overburden you all with this. So I'm open to any questions or any other clarifications from Dr. Ariola, Derek.
I have a question about what you said. So you're saying that we haven't been checking? We have been checking, right? Because we've been validating.
So we, towards the middle of last year, we did receive communication from the state regarding some of our program, CHAN CSS, and we also sought clarification from Metro Legal regarding our breast and cervical cancer programs. And it's not, again, it's not routine. It was not routine to ask for immigration status all the time for the different programs. And so, but once we were asked to check that so it was two parts. We were asked to ensure that we check the status for new enrollees, but also to retroactively redetermine those that are already there. We, working with Metro Legal, we did work with the state to ensure that the CSS, which is where our most vulnerable persons are, that they continue to have access to care. And we have opinion regarding our breast and cervical cancer program, which we will. So keep in mind, all of these laws does exempt things like communicable diseases, infectious. So it's not total for everything that we do. So there are exceptions in the law. So it's not necessarily what we do in every program. Yeah.
Okay, thank you.
Any other questions? And
I didn't see anything about exemptions in there in what I read.
Maybe Derek can talk about that, but the original law itself started does have this is just as Cabrera said, it's putting in local health department and other stuff there.
And also, we don't have the final wording yet, but also understand federal provisions. We don't have the final language to complete analysis of what may or may not end up being in the law from a state perspective, but there's always federal preemption of some state requirements. For example, I suspect communicable disease and therapies, since that affects regardless of citizenship, directly, I mean, illnesses spread, and so even the federal government has recognized that anything in the category of communicable illness and all the funding dollars related to that are able to be used without regard to citizenship or legal status. So that likely would still be part of an analysis, but we just haven't begun to engage in that speculation at this point.
Dr. Ariola,
It doesn't mean that opposition to the bill can't be stated, but legal's not yet ready to provide a full where you shouldn't verify, where we're preempted,
that's kind of the exercise he was alluding to. We began on state programs several months ago, and there was also recognition under their requirements. Communicable disease was still treatable regardless of immigration or citizenship status. That's just an example.
Dr. Ariel, I know you're going to weigh in, but before you do, you can probably consider my question also in your response. Do you have an understanding of, is this inclusive of health education efforts in the community?
I don't know that that's called out specifically. I don't recollect seeing that.
That requires an analysis of public benefit.
Yeah. But Dr. McDonough has worked on this. You can chime in also.
The understanding has been if there's general community efforts, so large-scale education, et cetera, that's different than a public benefit, how public benefit is defined federally by the statute. And in that, as Derek mentioned, in the federal public benefit statute, there is an exemption for communicable disease. It's not clear in this statute what is or isn't covered and what's exempted and what's not. But the public benefit is what they are, what this bill is about, who's eligible for that public benefit. And so in federal statute, there's also exemptions for nonprofits, but that's not covered here. In the testimony earlier this week, they did say this does not apply to nonprofits and nonprofit grants. We'll see how it's being amended a lot. This one and 1711 are being amended quite a lot. And so I think, and I appreciate the comments that were made earlier, certainly from our duty to protect the public from communicable disease, to ensure health and wellness. We want to make sure that we're able to continue to do that. And that's difficult if the burden of immigration enforcement is put on us. And similarly to our patients who might be fleeing domestic violence, who might be experiencing homelessness, they are unlikely to have a birth certificate and other verification means. So we want to be able to protect the public as public health does.
Yeah.
And I've had several conversations with health officials at the state. I am happy to engage you and get into more details about those conversations. I would just say that, we are monitoring that. We're working with them. There's some fluidity to what's going on, but happy to get into more details with anyone who is interested.
I also, in reading through the bill, in the fiscal note, that there is not an allocation that will be passed down to the locals to accommodate the operations that it would intake. Is that your understanding as well, Ms.
Yeah,
Leach?
that is my understanding as well. So that's another issue that I think they would have to discuss, and hopefully when they go into the state and local government committee next week, maybe that is something that comes up as a topic of conversation, because this is going to cost money, and there should be some allowances for people to adhere to this legislation should it pass, but that's my understanding as well.
Just had go ahead.
Just to kind of piggyback on that, reading through the fiscal memo, and if you haven't had an opportunity to read the fiscal memo, there are some points in there that are important to read. They really did minimize the financial impact and also minimize the human resource impact on local departments. So I think, gathering thoughts about what the reality of that impact would be, especially given that the runway is not long to July 1st, if this does pass. So, in reading through this today, my primary concerns were really about how this would look in practice, as opposed to what it is in theory. And I think you've answered a lot of that.
Okay. Thank you.
Yeah, I want to thank you. This was a really helpful summary, both written and in your presentation. So thank you. I did have a question for Dr. Areola, and speculation is probably something you don't want to do, but I'll ask you to speculate. The really two big impacts that I'm hearing raised. One is the people in the community we serve, and you probably can't even estimate, what percentage of people this would affect that come in for services now, let alone the ripple effects within families and households. But a couple times was raised just the effect upon staff here, it's kind of the moral distress that people would have. Again, I'm asking you to speculate, but I'm imagining that would be a significant impact already on staff and programs that are stretched and maybe understaffed. And just maybe I'm asking you to kind of help me think that through. What does this mean? What would this mean?
Yes, so I think the bigger impact, the more concerning impact, is on the health of our residents. Our goal is to ensure that everyone, no matter what their health status is, race, immigration status, can be as healthy as they possibly can. There's also the population health aspect of it, where I think immunization is where we say that quite a bit, where, you get certain percentage of the population vaccinated, they provide immunity. So those are concerns there. For some of our programs like CSS, it's some of our most vulnerable people that are there. It's typically like their last resort there. So you're going to have very direct impact. And I will have to put the numbers together. We can really look at people that have lost their eligibility based on this, and we can also look at the rate of enrollment previously versus when we were told to change that. Our breast and cervical cancer screening program, tough, like you said, to give you a particular percentage, but it is used by the public, and largely, we are one of those entities, along with the FQHCs and safety nets, where people have access that maybe otherwise they would not have had. And so tough to estimate, but there's no question of the significant impact. Now, talking about the, we are trained to do a lot of things. We're not trained to keep immigration records and those things. So as Dr. Laura Vanier and I spoke about that today, our breast and cervical cancer screening program is now going to begin to look at how to implement this, which is a change to our processes, a change to how we keep things, and so it's very significant. So think about it. It just absolutely increases the length of time that you take to screen and to register an applicant. The reporting requirements, like people have said, it's a huge undertaking given the number of clients that we serve. And last year, when this was implemented, number of us across the state, really within the first few months, according to unofficial records, thousands of people lost eligibility. So the impact is going to be huge on population health moving forward. That's our biggest concern. I think our staff are going to adjust to this. The impact on resources, absolutely, but the bigger impact is on the health of the population.
And not just those that are directly impacted, correct? But if you only have 2 individuals that are serving a population and now they have to add another work stream, then everyone gets impacted, right? Everyone that comes through the doors.
Everyone gets impacted. Everyone. Unless magically resources appear from somewhere else, we still have the same number of staff that are going to have to ask longer questions and keep those health data safe and secure, and do reporting requirements and educate people that come in. So it's a huge undertaking.
Thank you. And Dr. Ariola, I know you're going to keep us abreast of everything that's happening. And Ms. Leach, would you please remind us the subcommittee meeting on Tuesday, the 24th, I believe it's at noon?
Yes.
In the Tennessee General Assembly in the House.
Yes.
I plan to be there. I would encourage others to share this information in the community, and encourage folks to follow and lift up their voice accordingly.
Yeah, I'll send the calendar to Leah, and you can send it to the board for me. All right.
And just kind of public service announcement, for those that are not aware, you can follow all the bills in the General Assembly. We've got a great website, capital.tn.gov.
Yep.
You enter the bill number, and it tells you exactly when it's going to be heard where.
Yes.
All right. Thank you, Ms. Leach. All right, our next agenda item, Public Health Wins presentation. And we have Bird and Sheely, and I'm not sure who's who, so I'm not going to use titles, but please introduce yourself.
Hi, good afternoon. It's so nice to be here. We're so excited. My name's Allie Bird, and this is Bob Sheely.
Hi, I'm Bob Sheely, the Workforce Development Manager.
Bob and I used to work very closely together. I used to be the evaluator for the Public Health Infrastructure Grant. I have since then transitioned over to Population Health, but we thought this would be a great opportunity to present the results to the PH-WINS Workforce Engagement Survey. Sorry, tongue twister. Do we say next slide or? Okay, thank you so much. Before we dive into the data, I thought we should go over some information just so we're all on the same page. PH-WINS stands for the Public Health Workforce Interest and Needs Survey. It's hosted through the de Beaumont Foundation in partnership with ASSO. It's conducted every 3 years. We did not participate in the 2021 round, but we did in the 2024. Our response rate was 41%, which was slightly higher than the national average at 37%. From what I understand, we did do an internal survey back in 2017, but our response rate was less than 15%, and I've yet to see what the results were on that. So realistically, PH-WINS gave us the first what's it called? The first idea of how our workforce was doing since pre-pandemic era. There was 4 key findings to this survey. The first one was that we still have a very committed workforce to the public health mission. We have a lot of people that are interested in leadership development and policy engagement training. Retention is still a risk within the department, especially when it comes to burnout, opportunities for advancement, and pay. And then last but not least was that we have a lot of workforce investments already underway because of the results of this survey. All right, there are some important considerations to have for this survey. The first one was that there was a long turnaround time to get our results. This survey was conducted in the first quarter of 2024, but we did not get access to our results until late August 2025. So it was a little over a year and a half. Second is that PH-WINS relies solely on self-reporting responses. This is essentially a snapshot of people's perception of the department in 2024. So it's not necessarily an accurate representation of what's going on today. We also might have over-representation of one program. Of the 41% that responded to this survey, 30% of those responses came from one program, which is clinical services. You know, shout out for them for partaking in this. They did awesome, but these results might weigh more heavily in their perception. And then lastly is that public health metrics might differ from other sectors, so it might be a little misleading to compare us to other industries, and you'll see how we kind of avoid that and when we talk farther down.
Okay. As Allie shared, 41% of the health department participated in the survey, which that beats the national average of 37%. That's great. But sitting juxtaposition to the 41% is the 59% who did not participate. It's important to understand why people don't participate in surveys.
The microphone up. There you
Thank
go.
you.
Yeah. No, he was, yeah, he's tall.
Okay, so why this slide could be titled "Why We Don't Take Surveys." Number one is we're just not interested. People just don't see the value. They might be happy. They might be enjoying the status quo. They don't see a need for a change. They don't take the survey. There's not a pain point today. Secondly, they question the anonymity. Is this confidential? Root word of confidential is confidence. Do they have the confident assurance that what is shared won't be brought back on them? Do they have the confident assurance that they won't get in trouble? Those in this group have information to share. They want to provide input, but they don't have the safety. They don't have the feeling of safety that what they're saying will be protected. Glass ceilings. Not to be confused with the glass ceiling effect. This is a colloquial glass ceiling where someone feels like they're just stuck. They can't go any further. Those folks might not participate in a survey because they don't see where it's going to provide them better pay. It's not going to provide them an enhanced stature in the organization. It's not going to fuel their career adrenaline. I could put a bullet point in here that says ineffective pre-marketing of the survey. Surveys are notoriously not pre-marketed, or successfully marketed pre-deployment. Yeah, with that, the value proposition is not in place, and the respondents aren't understanding what it is that this survey can potentially do for them. And finally, what I think is the most important is folks think that nothing's going to happen. A lot of that is a result of history. I'll be vulnerable. I'll open up. I'll provide input. What next? Okay, for illustration purposes only, not artistic purposes. We have simple bell curve. You'll see the axis. On the lower side of the axis is what we'll talk about first. But before I say that, every survey, every poll, every questionnaire, every election will have participants who are predisposed. Surveys are no different. Under one axis, and it doesn't matter which one we're looking at, under one axis there will be those who are predisposed to the negative. Not a thing in the world we can do to make them be happy about where they're at. There are those who are predisposed to the positive. They're going to find the silver lining in every cloud. There's nothing we can do to make them dissatisfied in their workplace. We love those people. In the vortex lies the voice of the department. It's there where the non-predisposed sit. I'll make the analogy of an election. And in any election, you're going to have folks who are going to vote one way or the other. No way that's going to change. Oftentimes, it is the independent voter that sways the election. It's those non-predisposed who will sway the outcome of our survey and give us the feedback we need to impact the culture.
All right, here we have a chart that shows tenure in position, and I mentioned earlier how comparing our metrics to other industries might be misleading. So I thought it would be most appropriate to compare our numbers represented in the navy blue to the State Department, which is Tennessee orange, and then to national, state, and local health departments that's represented with the lavender. And even though our trends are pretty similar with one another, there's still some noteworthy takeaways from this. And from an evaluation standpoint, this tells me a couple things. The fact that most of our workforce has been here less than 6 years means that we have a young workforce that's still settling in. A higher proportion of early tenure staff often means lots of new hires or lots of room for new hires. The average time to hire in MPHD is over 60 days. So that can mean programs operating with staffing gaps or people taking on extra work to their workload, their normal workload, which can all contribute to burnout. A second thing I see is there might be a limited depth of institutional knowledge here. That also can contribute to higher onboarding needs and not enough long-standing staff to serve as those mentors to provide that historical context.
Can I ask a quick clarifying question? This is of the respondents. This is not our HR data, correct?
No, this is of the people who participated in the survey. Solely, everything you see today is that.
Okay, and can we go back one? Can we go? There we go, thank you. Just as with tenure in position, those with 0 to 5 years of service with the health department led the responses. Those with 0 to 10 years of service with the health department made up 71% of the responses. So those are our data points. Data points don't have lives of their own. They don't live in a vacuum. Data points are starting points, they're not ending points, especially when we're trying to understand the human variable. So, what is our data telling us that we're not hearing? What is our data showing us that we might not see? 3 points. One, in the area of talent management and succession planning, popular topics in organizational development. The average, what is considered a generation in American society and culture now is 15 years, whether it's baby boomers, Gen X, millennials, Gen Zs. 15 years is considered a generation. So, if we operating with that in 15 years, one generation, if we retain them, train them, and develop them, where are those 0 to 5s on the bottom line of the chart? They're at the 16 to 20. The 6 to 10s, who make up the rest of that 71%, are in the 21 pluses. Today's 0 to 5s, today's 6 to 10s are the succession plan. They are the future leaders of the health organization and the next generation and the next, and they're training and deploying the next. They're the ones in the future who are going to protect, improve, and sustain health in Metro Nashville and Davidson County. They're talent that we have today that we want to mature today. And point 2, data point shows that our succession mentees, plannees, they want to engage. They're hungry to engage. They're interested in being a part of progress. They're interested in having a seat at the table. But as they want to engage and as they want to participate, they want to be engaged. They want to they have the unspoken expectation of engagement. They're looking for quid pro quo. They want something for something, contingent upon, give to get, information into action into outcomes. They'll offer input, they'll offer tremendous effort, but they want to be engaged. And point 3, the 0 to 5s are the most likely to engage, but the concern level is they're also the most likely to leave us.
All right here we see the top reasons people were leaving in 2024. The number 1 driver for turnover was pay. We had 60% of respondents reporting being dissatisfied with their pay. And then the second was burnout. This continues to be a major challenge in the public health sector everywhere. This is often driven by workload imbalance, staffing gaps, emotional strain, or possibly lingering effects of the COVID-19 pandemic. Third was lack of opportunity for growth. People aren't leaving because they want to, they're leaving because they're not seeing that path forward clearly. Fourth was job satisfaction. This wasn't so much what they do for their job, but more tied into team culture, communication, supervisory rapport, and recognition for what they do. And last was other opportunities outside MPHD. That's what naturally happens when those first 4 items aren't lining up.
How does this compare? How does this compare to other health departments, just generally?
Across the board, pay is the number 1 driver everywhere, by far, by a lot. So, but they're all pretty much very close. There might be some difference in the first 2 or 3, but with pay being the first, yeah, these tend to be the top 5. Next slide, please. All right, PH Wins also asks employees where they want to receive training and development. The most requested one was budget and financial management. People want to understand the financial systems and the budgeting processes. These are often seen as mystery zones in public health. Second was policy engagement and change. Employees want to move beyond service delivery and help shape the broader landscape of public health. Third was change management. Staff want the tools to navigate change, whether that's new leadership, new systems, new priorities. They want the tools to navigate it, not be overwhelmed by it. Fourth was systems and strategic thinking, understanding how programs connect across divisions and how MPHD fits into that broader public health system and its goals. And fifth was community engagement, showing a continued commitment to authentic community collaboration, outreach, and forming of partnerships. To me, these requests aren't random. These are all great attributes of leaders, of people who want to grow within an organization and have that organization grow with them. Next, thank you. All right, on to my favorite, which is turning data into action. What have we done with the results? Starting in March of 2024, we launched the New to Public Health Residency Program through the University of Wisconsin. 80% of our workforce reported having no formal training in public health. So FIG fully sponsored new staff to build foundational skills as they entered the field. And then in March 2025, we hired a community partnerships coordinator who has expanded our community presence and built more connections for us with local partners. In July, August of 2025, there was a salary increase, at least department-wide, due to the cost of living adjustment and merit adjustments. This directly addressed the #1 reason for turnover, which was pay. And then in September of 2025, we hired Bob, our workforce development manager, who is leading efforts to retain, support, and engage our staff through what we hope to be long-term careers here. And then in November of 2025, we launched the BEAM program through the University of Miami. BEAM stands for Building Expertise in Administration and Management. And this program focuses on budgeting, financial systems, and leadership, which were all top training requests through PHWINS. All right, so we took some steps in the great direction. How do we keep that momentum going? #1, continue to keep salaries competitive. I don't know if any of you have paid an electric bill lately or bought some groceries, but something tells me that the cost of living in Davidson County has no plans of slowing down. So we need to make sure that we're keeping up with the cost of living so we can retain our talent here. Second was to deploy an in-house survey. This will allow us to do check-ins with employees more frequently instead of every 3 years with PHWINS. It'll help us track change over time and address workforce needs more rapidly. Third is to review internal policies and invite employees in on those conversations to build trust and transparency and shared ownership within the department. And then fourth was to create pathways for growth and promotion. We saw that retention drops after that 5-year mark, which tells us that people want to stay and grow. And again, the last one is engage employees in meaningful development, because they do want to grow. And if we build the skills of our employees and help them grow, our organization's going to grow with them.
So as Ally referenced on the last slide, one of the strategic workforce opportunities identified is a survey program. The Employee Satisfaction and Engagement Survey is the best tool to gain a single effort understanding enterprise-wide of team members' thoughts, feelings, perceptions, and ideas about the organization. Using the 2024 WINS survey as our benchmark, we will continue the employee surveys this year, next year, and the year after. This year after year after year set of revelations will allow for measurement of us against us. It will allow for measurement of ourselves against ourselves. There's going to be unique and creative pre-deployment marketing, so the survey is expected and the survey is well received. The outcome data will be communicated quickly. It'll be communicated to leaders, to managers, and most importantly, team members. There will be engagement leadership targeted actions working with the leadership team to identify areas where we can strengthen our workplace culture as a result of the feedback from the survey. Support's going to be offered through leadership sessions to our managers. Decisive action is going to be taken. So the tagline there is conduct, analyze, report, act, repeat.
All right, before we wrap up, I do want to share that we have published all the results to our survey on our intranet page. You can find them under the resources tab under the PHI grant. And if you scroll to the bottom of that page, there's a clickable link that says 2024 PHWINS survey results and action steps. And with that, next slide, we just want to thank you for your time and attention and open the floor for any questions or comments you may have.
So I want to say thank you.
Yeah.
I've been on the board for several years now, and there has been a lot of talk about our workforce and the culture and opportunities for growth and and attrition and just the hard work that people in public health do. And this really pulls it all together. And the fact that you mentioned that there is a path forward to make sure that the CARA, conduct, analyze, report, act, and then repeat.
Analyze, report, act.
And repeat. And that you have plans to make sure that we continue to monitor and survey within the 3 years that DeBeaumont does there. That's fantastic. So I'm excited. We don't have access to the intranet, but maybe if we have questions, we can just email you all for specific information. So thank you so much. This is exciting work.
Thank you.
What is the reasonable expectation for our participation rate, given, the marketing that you're proposing?
Participation rates we've seen them be all over the place, as Ali indicated. The last one that this department had done previous to the 2024 had a participation rate of 17. Ali and I interviewed the City of El Paso Public Health Department. They had a participation rate of 73%. The general thought that we have among our group is we had 41% participate, and I understand we beat national average, but we understand what less than half the people are thinking at that time. I would love to see the number be around 75%. We'll never capture everybody, but I think if we get out and we do the creative pre-survey marketing, that when we deploy it, they're ready for it, they're expecting it, and they'll participate.
We've had employee surveys in the past, maybe about 7 years ago. We've gotten up to 59, 60%. But your question about national average, if you get 75%, that's exceptional, and that's got to be the goal. But it's a standard conversation around survey. Keep in mind, though, it's a department of almost 700 employees. So the percentage may seem low, but really as we make deductions from statistical analysis, that's not really bad. The only concern here is tilted towards clinical services. So there's a couple of things there. Number one, some of the changes in the workforce. When we did this analysis of HR data about 7 years ago, it was about 50% of our employees had been here 5 years or less. There's so many reasons for that. For a long time in public health, we talked about the retirement of the baby boomers, so we knew there was ongoing changes in the workforce across the country. So obviously, if this was done in 2024, you have to consider the impact of COVID. I think that's part of the burnout. You have to also consider that in government work, there's not a whole lot of opportunities for move up. That's always a constant that you will see, even though we've tried to create those paths so that people can have opportunities to move up. Excellent job, I agree. Really similar to what you see in other health departments, but I think 75 is a good target. If we get 50s, I think that's also pretty good.
A question about the turnaround time. Is that typical, like around an 18-month period for results? Because you can understand why people would continue to feel like their input doesn't matter when they maybe aren't even tenured long enough to be around to see the results. So what would you expect, moving forward with another survey as far as the turnaround time?
When I joined and I heard that it took 18 months to turn the survey around, I was disappointed would be a fair word. We anticipate being able to turn the data around in 30 to 45 days. And we are talking to vendors.
Yeah. Now, I was just going to say, though, this survey was done nationally by the Bowman Foundation. So there are complications there. When I was in Maryland when this was done, there's some departments where they had less than 10%. They were trying, you get your data if you have certain percentage. So if it's done internally, that should be quicker, that should be faster. Although there are also challenges to doing this internally, but we can talk about it.
I do also remember hearing updates about the survey rollout and hearing from our ELT leadership that they were actively trying to engage individuals the workforce to participate. So they were on top of it internally in terms of trying to motivate, but I think you're absolutely right. I think it's a learning opportunity, but now that we have a team internally, we can make sure we stay on top of that.
one of the key measures we can evaluate ourselves on is in the repeat. How well did we do with the first one? The more that we were able to respond to the first one, the more they'll repeat and when we go around again. And so that's a self-check as well.
Yes.
And also echo of thank you. This was a lot of work to put together and a very comprehensive presentation, so thank you. I don't know if this is your team or a different team. One of the things that we've talked about as a board is that finger on the pulse from a workforce perspective, and being able to do that relatively frequently. So an annual survey that may be more in depth, but kind of the quick, like even quarterly kind of pulse surveys, 3 questions, like, and we'll act on it type thing. What's the status of that, and is that connected? Are some of those annual questions connected to these public
I'm
health
going to ask
wins
Dr.
questions?
Ariola
Yeah.
to answer
Yeah.
that.
So you're going to see that in our strategy plan. And
Great.
so we are committing to at least a year assessment of that. So again, the questions that we're going to ask, because they might not necessarily mimic what the Beaumont was asking in PH Wins for the pulse of the organization. Obviously, the conversion that we've had is to ask questions around the culture that we are promoting, questions around consistently providing excellent customer service, consistently commitment to continuous quality improvement. Those are questions. So because we've done this many times before, if you're asking somebody, are you happy? That's not useful for us. So it's question around the culture, but there's overlap between these, as you will see in our strategy plan document.
Thank you all so much. We look forward to learning more. Yes, thank you. Fantastic presentation. Okay, next agenda item, we're going to keep it moving, is the strategic plan implementation outline presentation. Now, I asked Ms. Leach to provide information sort of about where things are to sort of help us make sure we get to our retreat scheduled for April 14th. Yes. So for the sake of time, I'm going to invite you to review this outline, but we will go into depth with the strategic plan in April. Okay. All right. Okay, so that takes us on to the next agenda item, which is the report of the director.
Thank you, Chair Franklin.
I'm sorry, employee team recognition. I don't know
Yes.
why I keep trying to skip agenda items. Charge
Okay.
it to my head, not my heart.
All right. So, Matt, I'm sure we have that somewhere there. All right. Thank you. So, in the first picture that you see online is Miss Brenda Allen, who was our Employee of the Month for January. And some of the, as I've known Brenda from the time that I got here, she's worked with us consistently, and so you see words like dedication, adaptability, professionalism, saying, and when we had challenges, staffing challenges, when 3 members went out on medical leave and another resigned, the program was understaffed, and Brenda stepped up, and I'm quoting, in an exceptional way. She took multiple roles, answering phone calls, assisting dentist chairside, checking patients in and out. So she couldn't be here today, but I couldn't be more proud of what Brenda Allen did and what she has done in her years of service to the health department.
Please extend our appreciation to Ms. Allen. Thank you.
Yeah. The next one is our Employee of the Month for February, Ms. Asma Abuchar. As part of our interpreter services, she's also not able to be here. And again, the first sentence is she's willing to help, however it is needed. And today we served a family in our week office that needed Arabic interpretation and was also deaf. It took a combination of interpreter services, sign language, and writing in Arabic, which Asma helped with. So really, really, when I took the picture with her, I was very happy to express our appreciation for what she does. Typically, it typifies the things that we do, where we create an environment to be able to serve everyone, no matter what the challenges are, make sure they have access to our services. So, Asma, our Employee of the Month for February.
Thank you. And I appreciate us having insight into the details, the small things that keep our communities safe and healthy. Thank you. Next, Dr. Ariola, your report.
Right. So thank you all. First of all, to recognize our new HR manager, Mr. Graham McKissick. Graham?
Is he?
That's yes. No, you don't have to come. Just stand up so they can know you. You're going to be presenting. He started with us about 4 weeks ago, and from Tennessee Department of Military, and still learning the landscape. Excited at the opportunity to do QI on our entire HR processes, hiring processes, onboarding processes, and Mr. Graham is welcome to the department. And I do want to emphasize a couple of things. I want you have the report in your package. I do want to emphasize. Can you go to the next one? The community here. I do want to emphasize the community baby shower event that's happening on Saturday, March 28th at Titan Stadium with our partners. We postponed that earlier, and you are all invited to be a part of it. On that note, along the same line, Chair Franklin and I were on the Hill a few weeks ago with our other partners. You see some of the pictures. On top was our visit to Senator Marsha Blackburn, and below is Representative Matt Van Epps. We also visited Representative John Rose, and we we missed one, but we didn't miss it, we were there, but there was a little bit of confusion there. But it was a good opportunity to meet all of the reps, to tell them what we do in public health. I was prepared to talk about the Nashville Strong Babies with Senator Marsha Blackburn, which she and her team received very well. We did extend an invitation for her to visit our department, which was accepted there. We'll see how that pans out. Same thing with the Representative Matt Van Epps, also is very excited about possibly visiting us. So we're working on that. When they're coming, we'll be sure to invite all of us, as well as the mayor. But the Nashville Strong Baby program was, I think, very exciting for her team, and I don't know if you have anything to add to that.
I have a couple of things in my report.
Yeah. So other updates are in your package regarding director's report, and happy to answer any questions that you may have.
Any questions? Okay. So move on to my abbreviated report. So first and foremost, the retreat. Thanks for those that were able to send in information for consideration for the agenda. I'll be meeting with Dr. Ariola to pull that together. Hopefully we'll meet relatively soon. We'll get that on the calendar. Like we said before, there'll be the strategic plan. We'll talk about roles and responsibilities for the board and how it differs from that of the department. And also, I'll be able to we're going to start to sort of really dig into our roles and responsibilities. Now that we have a director for the long term, we can turn, and the department is stable, we can turn our attentions to making sure that we have what we need in order to have our marching orders and move accordingly. And so that being said, what I want to do is make sure that I bring back the information that I received when I went to the NALBO meeting. So when we were in DC, there were 3 meetings. There was NALBO, the National Association for Local Boards of Health, which I attended. There was NACHO, National Association for County and City Health Officers, which I know, Dr. Ariola, you're a member of, but you went to the Big Cities Coalition meeting, which we're also a member of. And then we came together for our visits on the Hill and coordinated. So you had folks in public health from across the country that converged on the Hill. Nature worked to help schedule the meetings, and we did have very good conversations about leaning into what is working and the bright spots, and we did extend an invitation for our legislators to visit the health department here, and so we'll be working to make sure that those visits are coordinated, and they were excited, and they all said yes. So, but I want to bring back that information, and that will be integrated into the retreat in April. And then lastly, I mentioned the strategic plan, and then that's all I have. Any questions for me? We're going to go ahead and narrow down. I know there's a hold on the calendar for all day. We're going to narrow down what that block of time is. It won't be 8 hours, hopefully, but I just want to make sure we're efficient with our time. We also will have a presentation from Derek Smith, Metro Legal, about our responsibilities for the board. The annual presentation that we always have, Derek. No, not tonight. See, you're not. No, at the retreat. We're going to set aside time at the retreat. So stay tuned for that. No, we're not trying to. Okay, yeah. I think people are ready to get on with their evening, so we're going to wait till April 14th.
Can I ask a quick question?
Yes.
So there's a regularly scheduled board meeting the Thursday before. Are we still having that, or is that going to be?
So what we originally, when we were going to have our meeting in March, we said we were going to skip the March board meeting. We had to align schedules, do the best that we can. There were only literally 2 days, maybe 1 day out of the month that all of us could get together. So we ended up moving it to April. And so what I have talked to Dr. Ariola about, and Dr. Ariola usually talks to Jim Diamond about, is making sure that we can get through that month that we have our retreat without having a board meeting. If there's business we need to take care of, we can notice that part of the meeting. And so in order to be efficient with that time, we'll work accordingly. So I don't anticipate us having a board meeting in April. I'm looking because we didn't specifically talk about April, but that is the cadence that we normally have every year. Okay.
I think that's what we'll work towards. If there's anything to be approved, you can have that section with during your retreat. Yeah.
Right. And if that does happen, then we might need that full day, but we'll be as efficient as possible. Okay. All right. Any other questions? All right. Thank you. That takes us to new business. Board requests of the department and departmental requests of the board. I don't remember hearing requests from us to the department today, and I don't remember hearing requests from the board, with the exception of we're asking all of us to please pay attention to HB 1710 and do our due diligence, and we will work on that.
Right. I think number 8, the under outcomes, we did send to you information about our budget improvement request. Mm-hmm. So, and we have a meeting with the budget office tomorrow. It's going to be a difficult budget year, and so it doesn't hurt if you let them hear your voice. Yeah. Using the talking points that we've given you here. Okay. Yeah. Thank you.
And who's coordinating that for the department? Who? If we have questions, who do we reach out to?
Reach out to me.
Okay.
Or Jim Diamond. Yeah.
Okay. All right.
But again, doesn't hurt to send an email the mayor's way.
Okay.
Based on those talking points.
Okay.
Thank you.
Thank you. All right. Anything else? Okay. That takes us to adjournment. I will entertain a motion for adjournment. Motion made by Dr. McDonald, seconded by Dr. Stovall. All in favor? All right, motion carries. Board of Health meeting adjourned. I hereby open the Civil Service Board meeting. I need to